Now we will move on to our next presentation. May I request Dr. Ajish Jolly and Dr. Ajit Shukla from Kanyakumari Government Medical College to present the case on peripheral vascular disease. I request the faculties for the last session to remain onto the dais. Thank you.
Good morning, sir. A 70-year-old gentleman, Mr. Venugopal, residing at Radhapuram, who is a daily wage worker belonging to low socioeconomic status, came with chief complaints of blacklist discoloration of left foot for 20 days and pain in the left calf for 6 months. History of present illness: patient developed pain in the left calf for 6 months. It is crampy type of pain, intermittent and gradually progressive. The pain increases and walking, and initially pain was relieved after taking rest, but the past 1 month it is not relieved even after taking rest. History of night pain present, disturbing his sleep and partially getting relieved by holding the foot tight and rubbing. No history of pain in the right lower limb. Blackish coloration of the left foot.
Is the patient is having the rest pain, or you are saying that patient is having the pain is continuously present?
He is having rest pain, sir. No.
What do you mean by that rest pain? Is it the claudication pain or rest pain?
Sir, initially he had intermittent claudication, sir. Then pain progressed. Initially he had pain while walking up to 100 feet. Then now it is reduced and...
so that you call as a rest pain?
No, sir. Now even at rest he is compelled to take rest.
No, my question is, when somebody has a claudication pain, for a claudication distance is reducing and he is getting a pain in the calf region. And is the rest pain you are meaning?
No, sir. He is also having pain in the foot and the other areas due to, it is maybe due to the shuffling of blood from cutaneous supply to the muscles. He is having pain over the foot and everywhere.
Why in foot, why not in calf? Rest pain?
Mostly distal vessels will be involved in rest pain. I mean,
it is due to what?
The blood supply will be shunted to the muscles, sir.
Why you get a rest pain?
Crying of the dying nerve, sir. Vasa nervosum of the lung will be affected.
So what is the status of your patient? What is he has?
Now he is having even rest pain, sir.
Now what is the importance of knowing whether the patient is having only claudication pain or rest pain?
So the severity will be increased, sir. In rest pain, it may, due to, it will, critical limb ischemia, sir. In claudication, we can go for just conservative management only if there is claudication. If even rest pain is there, intervention may be needed, sir. Blackish coloration of the left foot for 20 days. Initially it started at the toes, then progressed to the foot, sir. No history of trauma, no history of ulcer or discharge, no history of paresthesia, no history of pain on prolonged standing, dilated tortuous veins, no history of pain, fainting or blackouts, no history of chest pain, palpitation, dyspnea on exertion, no history of abdominal pain, no history of blurring of vision, no history of color change or pain in the upper limb on exposure to cold. Patient is a known diabetic for 5 years and he is on regular treatment with OHA. He also smokes 4 cigarettes per day for 30 years. Comorbid illness. He is a known case of diabetes for 5 years on tablet metformin, 500 milligram BD. No history of hypertension, TB, asthma, epilepsy, cardiac illnesses or CV in the past. No history of any surgeries in the past. Personal history: he smokes 4 cigarettes per day for 30 years and it is smoke index of around 120. Consumes alcohol twice a month for 30 years. Mixed diet, bladder and bowel habits are normal. Sleep pattern is altered due to pain.
A very disciplined person. Only 2 times alcohol per month.
Sir, he says once or twice. Family history: he is married, having 2 children. No history of similar illnesses in the families.
Is it important?
Yes, sir. Family history, and he is having children, sir. There is no history of impotence, and also PVD has familial.
Why do you get impotence?
Sir, if there is aortoiliac occlusion, there will be occlusion of the internal iliac artery, and so internal pudendal and penile artery is a branch of internal pudendal will be obstructed, so there will be impotence, sir. Dorsal penile artery will be supplied by internal pudendal artery, which is a branch of internal iliac artery. So in aortoiliac disease, there will be impotence, sir.
It's a bilateral aortoiliac disease.
Bilateral.
How much is the claudication distance now?
Sir, initially he had pain while walking up to 100 feet, sir. Now he is having pain up to while walking less than 30 feet, and even at rest he is having pain, sir.
Okay. You said the blurring of vision. Why there's blurring of vision?
Sir, in other atherosclerosis and other system artery involvement in ophthalmic artery and central retinal artery involvement, there will be blurring of vision. Most of tubular vision will be.
Any other eye sign is more important?
Eye signs, sir.
Yeah. Eye symptom.
Flash outs.
Outs.
Yeah.
That indicates what?
Hemorrhages fugax.
Yes, please.
Hemorrhages fugax, sir. That is central retinal microthrombus in the central retinal. So, patient having a curtain like a.
You indicate carotid artery disease, chance of high stroke is there. So, in a patient with POVD, there's hemorrhage fugax. That indicates the possibility of stroke. Okay.
So why do you get claudication pain?
So claudication pain is a intermittent crampy pain due to reduced blood supply to the muscles. It will be reduced on taking rest, and it is a reproducible pain.
Then why there is a relief of pain in case of type 1 claudication or grade 1 claudication?
Sir, initially while walking he will have say aggregation of substance P. When continuous on walking, there will be the occlusion, it will be washed out, sir.
How?
In mild stenosis.
No, who is washing it out?
Sir, collaterals and.
No, collateral is still there. Grade 2 also collateral is there.
Mild stenosis, the.
All waste products are vasodilators. So whatever it is, it dilates the major vessel also. So mild stenosis, the vessel gets dilated to normal position. As you said. Okay.
How the pain is produced?
Sir, in anaerobic metabolism, there will be accumulation of substance P. It is a neuropeptide which acts as with the glutamate, which is excitated neurotransmitter. So it will produce pain, sir. It's a best nauseous stimuli.
So glutamate is a pain substance. Okay, examination. Sir, anything else?
Examination.
After getting informed and verbal consent, examined in a well-lit room, a patient is conscious, oriented, afebrile, moderately wilt and nourished, no pallor, icterus, sinuses, clubbing in generalized lymphadenopathy, along with the bilateral pedal edema. No peripheral signs of hyperlipidemia. Vitals, pulse is 82 per minute.
What are the signs?
Sir, arcus senilis, then genthesma, then arterial thickening, renal artery hypertension also we can make out.
So why do you want to check for that?
For a patient having a hyperlipidemia, the cholesterol deposit in or fatty acid deposit in the skin or under the.
What is the age of the patient?
70 years, sir. So
you-
most probably I'm.
So can you get all the thickening without atherosclerosis also? The
Arteriosclerosis.
Yes, sir.
senile changes?
Nail changes also we can appreciate, sir.
But these are more important when you are checking for a relatively younger in.
If the patient is 40s or early 50s, that's very significant. In 30s also. But 70 or 80 year old man, this is not.
Or
Otherwise,
that
it's
vessel
okay.
wall thickening can be normal, because senile changes can be there. Arcus senilis can be also there in older individuals. Okay.
Local examination, inspection. Patients are both lower limb examined after asking him to undress to expose from
Yes.
to his toes. In attitude of the patient is sitting in the cot with both legs hanging down, hips flexed, knees flexed, and ankle on a neutral position. No obvious deformity in muscle wasting. Gait is antalgic, Dry gangrene of the left foot involving all the toes extending up to midfoot and laterally up to the ankle. Line of demarcation present. Surrounding skin was normal. No skip lesion seen. Signs of ischemia like skin is dry, lusterless, and brittle nails seen.
How do you know it is line of demarcation?
Line of demarcation between the viable and the dead tissue in a zone of hyperemia is present, sir.
It's a zone, no?
Yes, a zone, sir.
So it belongs to the dead tissue or living tissue?
Living tissues.
How it,
Living tissue.
how it appear?
Sir,
How it will appear, look like?
pale, gangrenous area will be dark black, sir. This will be like pale colored.
Pale color.
Hyperemia, sir,
One line
redness.
of-
Hyperemia will be pale.
Yes, sir. Redness is there, sir, erythematous. Like,
So it is hyperemic. What else?
Hyperesthesia will be there, sir.
Hyperesthesia will be there.
no hair present.
Why you are set in the sitting position rather than the lying posture? Attitude, it is better.
Sir, due to the effect of gravity, sir, so blood
So
flow.
even patient cannot tolerate the examination also.
Illa, sir. Attitude, he is taking this attitude most of the time. We will ask him to lie down while examining.
Okay.
That is, Vargas test capillary feeling and venous feeling could not be appreciated. Fustics cross leg test.
In Bajaj says, what you have done? Anything else you can note? Can
Sir,
you note
pain-
where is this angle?
Sir, pain, sir, but books they given color change, sir. But due to dark complexion in Indian population, we can't rule out Burgess test. But patient having a pain while elevating the limb.
What is, how much was the Bajaj angle?
For this patient, it's around 30 to 40 degrees, sir. If it is less than 20, it is severe limb ischemia, sir.
This patient, it was 30.
30.
So what could be its angle pressure?
Then 30, sir. It will correspond to the angle pressure, sir.
So, but you are not mentioned there, that you are not,
Sir,
pain, you are not eliciting.
Sir, Burgers test in books, it is given as color change. The paler will be noticed, sir.
so we didn't mention, sir. But now we are patient having a pain while lifting up the limb. We got the Berger angle, that is the 30 degree. No dilated tortuous vein seen. Palpation. Skin temperature of left foot is cold up to ankle. Then others area in right limb non-tender. Girth measure is mid calf circumference. Right is 26 centimeter. Left is 25 centimeter. Mid thigh circumference is 33 centimeter on both sides. Sensation was normal. No dilated tortuous vein.
No, what do you mean by sensation normal? You say it is cool. That means the temperature is not a sensation.
Sir, temperature of the patient is cool, sir, but he can appreciate the temperature, sir. When we are doing with external, he can appreciate the temperature.
Then no inguinal lymph node palpable. Movements normal at hip, knee and ankle joints. Peripheral pulses on left side, popliteal, anterior tibial, posterior tibial and dorsalis PDS was not palpable in compared to right side. In upper limb, bilateral, superficial, temporal, facial, common carotid, subclavian, axillary, brachial, radial, ulnar arteries are palpable. Auscultation, no bruit heard. Systemic examination was normal.
Where
So-
did you auscultate it for bruit?
Sir, bruit will be heard proximal to the occlusion, sir. So in femoral region, carotid bruit and subclavian bruit.
In epigastric region also.
Bro is proximal.
Sir, distal, the turbulence of the flow will be heard as bruit, sir. So at the,
Verticals. How the turbulence happens?
sir, occlusion, distal
Will the occluder segment produce a turbulence?
If you occlude a vessel, will you get a turbulence? Is it absence of bruit is indicate there is no obstruction?
No, sir.
No.
When there is a complete occlusion, there will not be bruit heard.
Ah.
When there is partial occlusion, there will be bruit
Yes.
heard, sir.
Then jet happens, distal blood comes, partial occlusion, jet. The jet produces the bruit.
So
Yes.
Brui head over the
Or and just
proximal
just after
distance,
that. You take a pipe and inject it and some water into it. A pipe is partly occluded, the jet. The jet produces.
So summary, 70-year male diabetic smoker presented with complaints of claudication pain in the left calf 6 months, rest pain 2 months, gangrene in the left foot 20 days. On examination, dry gangrene of the left midfoot with absent peripheral pulsation distal to femoral artery with signs of peripheral ischemia. So my diagnosis is peripheral artery occlusive disease in the left lower limb with a gangrene of left foot. Probably due to atherosclerotic etiology, and label of obstruction was femoropopliteal.
So can you give me the 4 features of a claudication pain? Basic.
Sir?
What are the
Clinical-
characteristics of the claudication pain?
Pain. 4. 1, 2, 3, 4.
Say that the claudication
Claudication pain will be intermittent, crampy in nature, relieves and rest, and it will be reproducible, sir.
Will it be present on rest?
No, sir.
Where exactly occurs?
Sir?
Where it will be present in the lower limb.
In the calf, thigh, and in
Which
gluteal
structure?
buttocks.
Depending upon the
Occlusion.
calf, thigh or foot.
What structure?
Muscle, sir.
Only muscles. Okay.
Muscular pain.
Yes.
Okay.
Grading. What is your, in this patient, grading?
Grade 3, sir.
Grade.
Boyd's grading will be used for intermittent claudication, sir. Grade 1, patient will develop pain and for when walking certain distance, and he is able to walk. Continuous walking will relieve the pain, sir.
Pain disappear.
Grade 2, he will take some rest and then he can walk again, sir. He will walk with effort.
With
Limping
effort.
is there, sir.
Walk with effort.
Yes, sir.
Grade 3, he is asked, he is compelled to take rest, sir.
What do you mean by peripheral artery?
The arteries which is not supplying the coronary and cerebral vessels. Is,
So what kind of ischemia you are expecting here? Chronic or acute?
chronic ischemia,
So
sir.
have you any grade you have for a grade chronic ischemia?
Yes, sir. Fontaine grade and Rutherford grade. Rutherford 0 is asymptomatic, 1 mild claudication, moderate claudication, severe claudication, 4 is rest pain, 5 is minor tissue loss.
Tissue loss. Then major tissue loss, sir. 6 is major tissue loss. Major tissue.
Minor tissue loss. What is major tissue loss?
So, 1 or 2 toes will be.
What is minor tissue loss? What is major tissue loss? Remember? Very good. Crossing the metatarsal, major tissue loss. Confined to digit, minor tissue loss.
What is critical limb ischemia? You said there's
Critical limb threatening ischemia. CL.
TI. Now calling the chronic limb threatening ischemia, sir.
This patient is
Yes, sir.
Yes, sir. So if we are doing a value is less than 0.4, so we will say
Persistent,
less than 0.4.
4. Then a persistent pains for more than 2 weeks, not going
Rest
to not going to subside with taking the analgesic.
Okay, rest pain.
Then
ankle pressure.
having the ankle pressure is less than 50 mm of Hg. Toe pressure is the less of 30 mm of Hg. Then toe brachial index is less than 0.6.
Why do you want to do toe pressure?
Because in the patient of the atherosclerotic, distal artery is not going to calcified. So that is the actual
Not frequently
digital arteries are not frequent.
yes.
So how did you do the antibrachial index?
Sir, we will check the pressure. For that is special.
ankle pressure.
which pressure will you check?
Which pressure you are checking?
Systolic pressure, sir.
Ankle, sir.
Angle.
Sir, first bilateral upper limb pressure we have to measure, sir.
For a right side lower limb check both bilateral?
No, sir. Bilateral upper limb we
Why?
measure, and highest of the one is we have put in
Why
denominator.
you are taking the highest? Or why you are taking both up?
So the stenosis is there. So
No, right side lower limb patient, you take only right side at upper limb, or you want to check the left arm?
symmetrical
No,
symmetry is there.
basically, two reasons. One is either upper limb may be affected due to some pressure. Second thing is, it means you are comparing the pressure to aortic pressure. So if you take the both upper limbs only, you can have the better aortic pressure. Okay. And the lower limb, what pressure will you take?
Lower limb, we can measure for dorsalis pedis, anterior tibial and posterior tibial, which is the maximum we will put in.
So your
This
patient
side.
already, pulse is not pulse. no?
Not palpable.
So how did
sir.
you,
With the Doppler, we can use a handheld Doppler.
Handheld
With,
so which pressure you have taken?
intake, sir.
நீங்க பார்க்கலையா? You didn't
Sir,
see
sir,
what is the
handheld
ABPA?
Doppler, I am not able to appreciate the sound, sir.
Zero.
Yes, sir. I'm in handheld Doppler, it is not heard, sir.
Not heard.
Not
Then
heard,
pressure is zero.
Not zero, sir, but we couldn't appreciate it on the affected limb, sir.
Okay.
Right.
So then you have done a toe pressure also, that is also not done.
Gangrenous foot.
Toe
sir.
is there, sir. So
So if there is one toe is gangrene, you can't do the toe pressure. All the toes are.
Up to foot, it is gangrenous.
Okay, up to foot it is gone. Okay,
Major
very good.
tissue loss.
So is there is any other way to see the pressure in the
Transcutaneous oximetry can be seen, sir. Specialized probe is there to place in the cutaneous, and if it is less than 40 to 70 millimeter. Yes, sir.
When will the wound heal? Below which level wound will never heal? Less than 30 will never
30
heal.
is very easy.
Will never heal. More than 60 is good.
Okay.
That is to decide the amputation level. Right?
How do you examine the posterior pulse?
Sir?
How do you check the posterior pulse?
It is felt between the medial malleolus and the Achilles tendon, midway between and against the
Dorsalis
calcaneus.
pedis?
It is felt lateral to the extensor hallucis longus against the first base of first metatarsal, sir.
On any particular tarsal bone or?
Navicular.
navicular.
Posterior popliteal?
It can be measured in 3 methods, sir. First in supine position with knee flexed to around 40 degrees, and it is felt against the tibial condyle, and the prone position with 90 degrees flexion against the lateral femoral condyle, and cross leg fusics test can be done, sir.
Okay, okay, fine, okay.
So suppose your angle brachial index is more than 1.
In calcified vessels, it may cause spurious value, sir.
Why it's increase in calcium vessels?
It is not compressible, sir.
Yes,
So
needs more pressure to compress it
Yes, sir.
because of calcium. Okay.
So what kind of this will be there in a diabetic foot? Is it in a diabetic foot will you do that angle brachial index?
Arteriosclerosis will be there, sir.
What is the specialty of that arteriosclerosis?
Intima of
What
the
is the
wall.
difference between atherosclerosis we are going to get in a normally and in a diabetic?
In media will also be affected,
Normally, sir.
Intima will be affected normally, and in diabetic there will be media can also be affected in monkey blood sclerosis.
Medium sized artery and media.
Is there is any role of segment measuring the segmental pressure?
Yes, sir.
Uh,
What do you mean segmental pressure?
So various segments of the lower limb will be different.
Calf, thigh and ankle.
Cough and angle will be separately measured. It will give a rough idea of level of amputation and level of occlusion and
When you say it is abnormal segmental pressure,
less than 60. Less.
is it? It is a depends upon the difference.
Difference of the pressure on that area particular, sir.
The difference is important rather than middle pressure. Okay.
How will you proceed after ABPA? You said ABPA
Yes, sir.
and
Yes,
toe
sir.
pressure. Then
Sorry.
To confirm the diagnosis, to know the level of the block in the involvement of the artery, I will go with the Doppler, sir.
arterial duplex.
Yes, sir.
What are significance of ABPI? Why the clinical use of ABPI?
To know the any intervention, sir, we have to do intervention or not.
One is intervention occurred or not, then.
It's a non-invasive.
Okay, clinical uses. Advantage is non-invasive. Okay, you can do in the OP room.
Healing of the ischemic ulcers can be roughly.
Yes.
Sir. Then after procedure, we can follow up the patient
Yes,
with ABPI.
very good. Even with or without procedures, follow-up is good. ABPI is a very good medium of follow-up. You can decide the mode of treatment. You can decide whether to treat it or not. ABPA is 0.8 asymptomatic patient requires only some walking exercise only that. Not medicine is required, no angioplasty is required. So you can decide whether to intervene or not. That's important. That's one of the very good tests. And ulcer will heal or not. ABPA is 0.4 or less, then ulcer will not heal with regular management.
So any conservative management you are putting that whether it is responding, can you assess with that ABPA?
Yes, sir.
Yeah, for claudication you can follow it
For-
with
for only the
ABPA.
ABPA.
See, any reduction in ABPA 0.1%, the 10% increase in
The-
stroke and MI.
Yes, sir, 10%.
And ABP is supposed to be one of the very good predictor for coronary and stroke, coronary stroke.
Yeah,
So surgical residents seeing a POVD patient, you should be able to elicit ABPI.
it's a warning sign.
It's a warning sign. So we should do it in everybody who is seeing the OPD. Okay.
Then,
What are the things you look in arterial duplex?
sir, in duplex we are using the B mode of ultrasound with the Doppler, sir. Doppler will give the physiology status, and the B mode of ultrasound will give the anatomical.
Yeah.
Like we
Image.
have to look the structure of the vessels, so we can know the extra luminal cause is there, in a lumen is cause is there, or in the wall itself or something is there. Then anatomical we will after that physiological we will look the flow of the vessels, then speed or velocity in a wave pattern.
What is the normal
What is a wave pattern?
Normally is the triphasic, sir.
Yeah.
Triphases.
First phase is the forward flow, that is we will get in the systolic, sir. Then we have a reversal of flow that we will get in early diastole. Then again we are getting the forward flow that we will get
Due to what?
due to the recoiling, elastic recoiling.
Muscle wall.
Yes, sir.
Okay. So first is a positive wave. Very strong positive wave shows systole. Second is a negative wave, diastole. And third is a small positive wave due to elastic recoil. Okay.
Recoiling.
Which one will disappear first?
Sir, third wave, sir, in the atherosclerosis.
What will you call it?
Biphase.
Biphasic, sir. Then again monophasic, then aphasic, sir.
Okay, fine. Then Doppler continues.
Then if we wants to do like now I know for my
You are
patient
going to do the Doppler for the which leg?
both legs, sir. So for intervention, if I want to do any procedure like percutaneous angioplasty, so we will prefer for CT angio, sir.
What test will you do before a CT angio?
RFT, sir. Renal function test.
Renal function
Okay,
test.
my patient RFT is
If
1
the
bar,
patient
creatinine
is-
is 1.6. What will you do?
Sir, first hydration of the patient, sir. I will hydrate the patient 24 to 48 hours. Then my patient was on metformin, so I will stop the metformin.
How long back? How many days you
2
stop?
days, sir. Then after
Why
that,
if it's not stopped, what happens?
Sir?
You missed the metformin. Your resident hasn't seen metformin, patient is continuing, patient is on metformin. CT angio is done. What complication can happen?
metabolic injuries, sir.
What metabolic?
Metabolic, like metformin induced nephro.
What metabolic abnormality? Can produce lactic acidosis. Lactic acidosis.
Lactic acidosis.
Yeah. You have to stop metformin for 48 hours before the procedure.
Then again we will check the creatinine value, sir.
Only hydration. Anything else?
Soda
bicarb, sir.
Always soda is not good.
Always so nice.
Any medicine, any drug which can improve the renal function?
Have you seen CT angiogram being done?
Yes, sir.
Yeah.
Any drug? Yes, NAC.
Acetyl cysteine.
NSS you have to give dosage?
600 mg, sir.
600 milligram? Yes, 603 times a day. At least start 48 hours before that, then continue till CT angio is over. When will you start fluid and when will you stop the fluid? Are you fluid?
After scan at least 1 or 2 days, sir. We will
Starting before that, then will you stop it?
when my procedure was completed, after the 2 days, at least 2 days, sir, I have to make a patient fully hydrated.
Yes.
So I have to give a adequate fluid
Till adequate urination is established.
Yes,
That
sir.
should be continued. Okay.
Then
No, still not responding. This urea creatinine is high.
then I will go for non-contrast MR angio, sir.
Have you heard of gadolinium-induced nephropathy?
Yes, sir.
What's it?
It is causing a fibrosis, sir.
Yes. Renal
Nephrogenic.
fibrosis. So which is more dangerous? Your ACT-induced nephropathy or
Gadolinium induced
nephropathy?
or CT induced is more dangerous.
Gadolinium induced.
Gadolinium induced, sir.
Only thing is,
How do you say it is? You will go for gadolinium in a patient.
Carbon dioxide.
CO2 angiography is also very good, sir.
so MRI is only thing you are delaying the complication for another 6 months. It can happen today or day after 6 months, that's all. So, if the patient's creatinine is abnormal, you have to maintain adequate hydration, maintain that hydration till adequate urine output after the procedure, control any infection. Infection can produce renal issues. NSAT16, metformin to be stopped, and patient should be informed that there is a chance of post-contrast dialysis also. May require 1 or 2 dialysis. Usually they may respond if it is properly managed. So these things to be informed in a written consent should be there. There's a possibility if the creatinine is more than 1 and 1.6 something like that, you have to get a written consent that he may land in for dialysis. But usually they will respond.
Usually,
Yes, please. And MR is not the right answer. It can produce a delayed complication, GIN. It's a fibrosis of the renal tissues which is non-reversible. So among the lot, CT may be more safer than MR angio. Yes.
that the CT angiogram, when you are doing with contrast, even with renal failure patient, 66% of the people will not go for renal failure even if you give contrast in full dose. Only 33% will go for. So if it is really indicated, you can explain the patient, you may need future dialysis and proceed with that.
And last thing is there is a renal friendly contrast is available. Non-ionic contrast. That also can be used.
Iohexol. What you are using is iohexol.
Iohexol.
That can be used.
Iodinated contrast.
Iodinated water soluble
Non-iodinated
contrast.
also
Can be used. So these are the 5 methods to make it renal friendly. But still it's possible. Okay.
What CT angiogram you are going to do?
From where, which area to which area?
What's an ideal CT angio?
From aorta, we will see from aorta to
Tattoo?
Lower limb.
Lower limb where?
Lower limb, toes.
toes.
Till toes, sir.
Yes, till the toes should be, see, then only you can call it as a, it should be seen from the renal arteries to that toes. Then it's a norm, it's a ideal angiogram. Okay. Angio is with you. What all things will you look into the angio?
So from starting from the aorta, sir, the diameter of the aorta, any calcification or aneurysms will be seen, sir. Then renal vein,
Patency.
renal artery patency should be seen, sir. Then common iliac, aortic bifurcation, there is a blocker. Then common iliac,
Most common cause there.
then
External iliac and then
internal iliac.
Okay, you say, okay, you see all the vessels. And when you say it's abnormal or if there is a lesion, how will you identify the lesion? What all things will you look for?
Sir, if aorta is more than 1.5 centimeter
No, this one is your patient
PVD,
CT.
no?
PVD patient CT. This patient CT angio.
What will you suspect in your patient by you? It is a superficial femoral artery block or femoropopliteal junction block. These are the two things, no? Either SFA is blocked at the origin or at the mid part, or otherwise it is in the distal part. Maybe femoropopliteal. What are the things you look in angiogram?
You have decided for a bypass angioplasty tomorrow.
So
length of the block.
Extent of the
Yeah,
block,
yes.
sir.
Very important.
length of the block is
What's
there, sir.
important?
So more, if it is less than, you can go for angioplastic
Angioplasty,
procedure,
yes.
sir. If it is more than 10 centimeter,
Then
you
open
can't-
bypass.
open
Yes.
bypass. You can.
Okay, then.
Then proximal run-in and distal run-off.
Yeah.
And
Needed.
Why distal
collateral.
runoff is important?
Sir, named vessel we need for anastomosis in the distal area. Also, the after anastomosis, there should be supplied
To the foot.
to the foot,
Yeah,
sir.
that is
So,
the answer.
what's the minimum amount of distal vessel required for
10
doing a bypass?
centimeter
10
should
centimeter
be
should be
there,
there.
sir.
If less than 10 centimeter, they will go for early thrombosis. Formation. Okay, then.
How do you classify this defect? What is task classification?
Task transatlantic inter-society consension, sir.
Yeah.
What are the societies? The two societies.
2007 it formed, sir, and it will look the...
No, she said transatlantic India societies. What are these? Just for curiosity.
Vascular...
It is transatlantic, that means
Here...
one side is
US and America, Europe.
Europe and yes, okay.
Yes.
That's history. Okay, leave it. Okay.
They will look for the single or multiple lesion, occlusion, and length of occlusion
type.
type, and divide it into 4 classes, sir. A, B, C, D.
Same for all.
Sir,
No,
no,
sir.
Different for
different for
Sir,
iotoiliac.
A is the single less than 3 centimeter involving in the common iliac artery and external iliac artery. B is the 3 to 10 centimeter involving the common iliac artery and external iliac artery. C is the 5 to 10 centimeter or more involving 2 artery more than 5 centimeter into the common external iliac artery, or it included the unilaterally common femoral artery. D is the more than 10 centimeter involving in multiple level and multiple segments.
In general, how will you differentiate? A, B, what is the treat?
AB we can go for endovascular approaches, sir. C and D open bypass surgery should be after.
So basically, look at the site, was aortic, which is the site, number of lesions, degree of lesions, there's occlusion of stenosis, and length of lesion. These 4 things are looked into for task, and classify A, B, C, and D. A is always angioplasty, D is always surgery,
B and C is
B and C is depending on the operator and his experience. What is legs?
Legs is lower extremity severity, legs lower extremity grading scoring system, sir.
Yes.
Having 5 component is there. It will indicate level of surgery or amputation, sir.
Very good.
If it is 0 to 9, sir, so we will go to the open surgery. If it is 10 to 19, then we will go to the endovascular surgery.
Very good.
If it is more than 20, then we will go for the amputation, sir,
Yes,
primarily.
excellent. Legs is one system which decide whether to treat or not to treat and how to treat. That's important. Okay. Okay, you have decided for a bypass. So what are the options available for your patient, femoral artery disease? You have decided for a 50 centimeter long lesion. You have decided for a bypass. Sir is doing tomorrow.
Only femoral popliteal segment.
Yes, sir.
Your lesion is in the femoral popliteal segment.
Yes, sir.
Your diagnosis from picture. 15 centimeter long lesion. Sir is doing a plan for bypass tomorrow. How will you bypass? What conduit will you use?
Sir, for low limb, it's better to go for a natural graft,
Graft,
sir.
Natural graft?
always.
When we are
Vein,
using,
sir.
sir.
Vein.
Great
Veins
subvenous
using, sir.
vein, we can give in situ or reverse vein
Siphons.
graft,
What
sir.
is in situ vein?
In situ, the same leg we can use.
Same place, sir.
Sir. In the same place with the valvulotome, we have to distract the valves and we can use.
Advantage of in situ bypass?
Sir, first is the less dissection, sir. We have to do the less surgery, sir.
Yes, less dissection, faster procedure.
Sir, then wound complication is also very less,
Yes,
sir.
yes, very good.
But
One more. Less dissection, less complications. You are not taking out the vein, so less
sir.
infection. One more.
less
Technical
time of
advantage.
hospital stay, sir. We
No, no, technical advantage.
sir.
Big vessel, big vein.
So
Small vessel,
size of vessel is almost
Yeah.
equal. When you reverse it, you are taking smaller veins to bigger artery
so
and bigger vein to smaller.
Size discrepancy is there. On
Size
that side,
discrepancies. Complication with but why you are not doing routinely if it's so advantageous? Why you are not doing in situ bypass regularly if it is significant?
Early chance of stenosis is there, sir. Because in valvulotomy we are doing, it's not going to full removal of the valve. So
Sometimes the valvulotomy may not work properly and patient going for early thrombosis. That's the issue, unless you are very experienced. Okay, fine. Then angioplasty.
after that,
Less than
roll of
5
angioplasty.
So less than 5 centimeter
Segment.
occlusion, we can go for angioplasty, sir. It is an invasive procedure where we use Seldinger method.
reversal.
What is Seldinger method?
Sir, guide wire will be passed and
The same leg.
Wire on the guide wire.
You have a right leg is affected. Where you
Right leg, if the problem, your patient is on the left side problem. So will you cannulate on the right side or cannulate on the same side?
Contralateral sides.
Yeah, opposite side.
Opposite side, sir. So
But there is
then,
a antegrade puncture also is there.
yes, sir.
That also can be done if the lesion is sufficiently lower than the.
Because you will not be able to get the adequate length.
Length.
So you usually go from the opposite
Opposite
side.
side.
Then lesion is find out
Sir.
Then,
using DSA. Then you put a balloon.
yes, sir.
How much you inflate? How long you keep the pressure in the vessel wall? How much time you keep the balloon inflated?
5 to
30 to 60 seconds. We inflate the balloon and keep it. Then when will you put a stent?
if adequate dilatation is
Adequate dilatation you got with the distal flow and appearance of pulse, very good. So if there is a more than 30% recoiling
then
on
go for
angiogram, you
med
go
test
for
and
stenting. More than 30% recoiling, go for stenting. Otherwise, we don't use stent. We always do plasty in the.
What's the common make of this? Usually what?
Nitinol, sir.
Nitinol.
Yes, sir.
Yeah.
Self-expanding metallic stent, sir.
The other one is stainless steel.
So now even people are doing up to the digital vessels.
Yes, sir. Yes.
Posterior tibial, anterior, sorry, dorsalis, pedis, posterior tibial and all, they do plasty. But below the knee, angioplasty is not very successful. But above knee, angioplasty are supposed to be very successful. In general, the distal vessels are very difficult to manage either in open bypass or in the angioplasty. But proximal the occlusion, better will be the result.
So suppose the block is above the femoral-popliteal junction, or if the it's involve the aortoiliac segment.
Aortofemoral bypass can be done, sir.
You see?
Bifemoral.
Bifemoral.
Bifemoral, sir.
Yeah. Or you can, if it is very focused, you can do aortic.
Arteriotomy, sir. We can do and remove the clot in
Endorthirectomy. Endorthirectomy.
If you want to use a graft, what graft will you use?
Dacron, sir.
Above groin, dacron.
Dacron graft.
Pent size they are coming, sir. Now.
There is no distal vessels. You cannot do a bypass.
Desert foot. What
Desert
will you
foot.
do? Desert foot. Non-reconstructible ischemia is otherwise called desert foot.
What are the options?
So what are all the options you give for
Your
the
patient
patient?
is having severe rest pain. You done a CT angio. Below that, no SREE.
Sir, lifestyle modification and medical management, sir.
எல்லாருக்கும்.
Then
Just particularly for the desert foot, the
gangrene சொல்றீங்க.
Severe rest pain is
severe rest,
இல்ல sir, with gangrene சொல்றேன்.
gangrene. Or with critical limb ischemia.
ஆமா ஆமா. Rest pain, severe rest pain with ulcer.
your patient. But CT
All
angio is
your
nothing.
artery is gone.
Nothing is seen. Completely damaged.
Anything else you have? No.
So to relieve pain, now you can go for sympathetic.
CT guided sympathetic.
Chemical
Yeah.
induced,
Done.
sir. Phenol 1:6.
Any other options?
On a CT guided sympathectomy. Then
Open sympathectomy இருக்கு.
open outdated ma. Please don't.
Nobody is advocating it.
Please don't do open sympathectomy.
Interventions
Always
are very
CT
strong.
guided. 100% alcohol we use to destroy the ganglion. It steals the blood.
Which ganglion?
Which ganglion?
Sympathetic.
Lumbar sympathectomy is a one
How many ganglion?
Which
How many
one?
ganglion will be there?
sir, bilateral L2,
No,
L3,
how many lumbar
L4,
sympathetic ganglion?
Total how many ganglion?
4, each side 4. 4 each side, sir. L1 to L4.
So you can block everything.
L1 we will not do, sir.
One side we will
Bilateral, one
spare
side
the
we'll
L1,
spare
sir.
L1, sir. L2,
For
L3.
75-year-old individual. No, why do you want to spare?
So importance.
Importance.
Patient
Not important.
retrograde
Ejaculation.
What is retrograde ejaculation? What is meant by it?
Sir,
What is meant by retrograde ejaculation? It is not importance.
Important is different.
ejaculation is controlled by sympathetic. Sir.
So
When
what
we
is
block-
meant by retrograde ejaculation? How do you ask the
Semen will
patient?
come to urine, sir. It
Yes.
will come through you.
Yes, it comes to urine only. Okay, then. One option is lumbar sympathetic, chemical lumbar sympathectomy, guided one. Then other options.
Suppose the vein is there.
Sir, arterialization of the vein can be done, sir.
Yes, what is, how do you do it?
In In situ.
The crural vein, tibial vein, may accompanied by venae committance. No, you can connect these two.
Yes, then
These are all
Omentoplasty,
trial level. Huh?
sir, omentoplasty we can
No,
use.
somebody is doing it for practical purpose, you can
Subcutaneous.
say that, not experience from my side. Yes, then
Have you heard about prostaglandin E?
It's injection.
Prostaglandin E can be given 160 microgram
Infusion.
per day for 3 days. You have to give 6 cycles. It improves the collaterals and it may help.
you ask the what needs to be PGE1, then what special instruction will you give the patient or a precaution? You are the resident, your house surgeon is waiting to give, what special instruction will you give to the house surgeon?
Pulmonary hypertension.
No.
Slow infusion should be given,
Why?
sir.
The nurse gives it very fast, she wants to go home.
Yes, slow infusion, it
So,
will make us
the nurse gives it very fast.
Hypotension.
Yes.
Hypotension.
Always check the hypertension,
Soft
check for
patient
BP,
will go in the-
check for hypertension, because severe peripheral vasodilatation can produce severe hypertension, and you should be careful about it.
So you have done the surgery, revascularization is done. What are the complications you are going to expect?
Sir, compartment syndrome and reperfusion syndrome.
Which compartment will be affected more?
Anterior compartment, the first to affect.
What is the nerve of the anterior compartment?
Deep peroneal nerve, sir.
So what will be the first symptoms patient will have? First sign, what will the patient will have?
So, pain, sir.
There will be loss of sensation over the first web space, sir.
What sign? Which muscles will go for pulsing?
Anterior compartment.
First-
Extensor muscles.
So what will happen?
Foot drop will be there, sir.
Drop will be there. So which one will be affected more? Nerve, muscle, artery, skin?
Nerve is the first one to get affected, sir.
Mm. What is the ischemic time? Reversible ischemia time and non-reversible.
6 hours, sir. Then after that, 12 hours it's going
So why
to
do you get the
reversible.
compartment syndrome? You are giving a revascularization, results are there.
Sudden opening up of the microcirculation, there will be
Muscles.
edema and more blood supply.
Like
so edema
before that
will be-
hypoxia is there, sir. So again, when normal circulation will come out, so more number of oxygen. So patient may be having the myoglobin muscles damage, sir. So myoglobin urea and
That is not.
Other
That is another reason. Compartment syndrome. It's only edema which is taking further.
When will you call this compartment syndrome? When it reaches what pressure?
more than 30 mmHg.
It's a standard for everywhere.
No,
depending on the venous
Venous-
pressure of that compartment, if it is more that venous.
So how many compartments there?
3 compartments are there, sir.
So suppose you expect the anterior compartment is damaged, and which compartment will open?
Sir, 2 compartments we
Should
should
be open,
open,
sir.
sir.
You will open all the compartments, but you make a 2 incision.
2 incisions.
2 incision, 3
Incision.
compartments we have to open.
So what is one is that compartment syndrome. Second one is
Reperfusion syndrome.
what is the mechanism of reperfusion syndrome?
Metabolic disturbance, sir. Oxygen will be delivered more.
Oxygen free radicals.
Free
more
radical
excess of free
injury.
radicals will be there. What biochemical abnormality will be there?
Hypercalcemia.
And hyperkalemia is there, so myoglobin urea and also will.
So how will you prevent reperfusion syndrome?
More of hydration should be more, sir.
Okay.
What type of lesion is this complication happens? Acute ischemia or a chronic ischemia?
Usually it comes in.
புரியல sir.
What
No,
type of
this-
patients will you get
you
this
said no, this-
reperfusion on the compartment
Chronic,
syndrome?
sir.
Chronic limb.
acute-
Come in
Mostly
acute.
Acute limb, sir.
Yeah, it comes in acute.
So how will you differentiate acute or chronic in a CT angio? Your patient is there.
Collateral formation will not be there in acute, sir.
Yes, then. One is no collateral, second is
So
Cause-
do you get a Buzzard's disease? You get a collaterals?
No, sir.
No, sir.
yes.
So that is the acute.
One is no collateral, second is
Emboli, most common.
total cutoff. At one particular totally cut off. There is no artery or evidence of any artery beyond that point. No reformation, no collaterals. It's total cutoff. If you see a total cutoff sign in a CT angio when you are doing a reversal, you should be very careful about these two
Reperfusion.
complications.
The patient is not willing for any surgery, anything. You have only option of a conservative. What are the ways you can do the conservative? If suppose not in the breast pain gangrene.
So first lifestyle modification, sir.
Stop smoking and
Then
start
not
walking.
Start walking, supervision, exercise, sir. So
What is the role of smoking?
So smoking will cause endothelial injuries, sir. Intimal hyperplasia and vasoconstriction.
also spasm.
Spasm will be there, sir.
What is TAO?
Thrombotis.
It's a vasospastic.
What is TAO? Can you abbreviate it?
Thromboangiitis obliterans, sir.
What is how it differs from atherosclerosis?
Sir, atherosclerosis will be in the older age, sir. TAO will be less than 45 years. It will be more in smokers.
Above 50 is older age.
No, sir.
So we are all people. Okay.
Sir, it will
So
be more in
what's the basic pathology change?
smokers.
Pathology change.
Pathology.
Smoking will cause endothelial injury and intimal hyperplasia, sir.
So it affects only the endothelium.
No, sir. Panarteritis.
Panarteritis.
It will
Now,
cause panarteritis.
Only artery?
Nerve,
nerve,
artery
artery,
and
vein.
vessels all are affected, sir.
Which
All-
vessels?
Nerve, artery and vein all are affected in the TAO, sir.
All vessels are affected. Okay, fine.
So what are the criteria that
Shenoy criteria, sir. Age less than 45-year male with smoking history. Then infrapopliteal occlusion starts first.
Any upper limb?
Upper limb involvement.
Upper
Upper limb
limb
involvement.
Which
superficial
vessel? Which vessel?
thrombophlebitis.
Most commonly?
Distal vessels.
Upper limb vessel. It's ulnar artery. So always check the ulnar artery pulse in a POVD patient, particularly young patient. If ulnar pulse is selectively absent, you have to suspect it's TAO. It is Socrates. Okay.
Absence of atherosclerosis
Take
promoting
like
factors.
diabetes.
Yeah, diabetes, hypertension, dyslipidemia. If it is there, it is not TAO.
Tail.
It comes under
Atherosclerosis.
so when the patient wants to, you said stop smoking and start walking, and anything else you advise?
Sir, antiplatelet drugs, sir.
No, walking with what?
Supervision, sir. Till pain,
No, any modification of the chappal you give?
Yes, sir.
No, என்ன செப்பல் கொடுப்பீங்க?
soft.
What செப்பல் you give?
Now ladies you see with a lot of with
Sir,
become there, you see,
heel,
is it a good or bad?
Sir, heel elevated.
What's
So
the
it is-
principle of giving a chapel?
Sir,
What's the principle of the
sir,
chapel?
heel elevation,
Always high heel?
high heels.
If a high heel QT lady shoe?
The foot and the pump will be. Sir.
The aim is to relieve the pressure,
Pressure, yes,
pressure
sir.
points. That's why they are doing a study the biomechanics by bathymetry, identify the pressure points and take away the pressure from that point so that no injury should happen there. That's the principle.
I think we have another 5 more minutes. Any questions from the audience? Do you have any questions? So what is acrocyanosis?
Sir, it is non-paroxysmal due to sympathetic overactivity. There will be painless discoloration of the distal digits, sir.
Is it old age or young age?
Young
Young age.
females, sir.
Okay, your patient is having no rest pain, he can walk around 400 meters, 60-year-old man, so how will you treat this patient? No rest pain, only a grade 2
So
claudication.
only lifestyle modification and exercise and antiplatelets.
Antiplatelets?
Statins and antiplatelets, sir.
Anything else?
Silostazole can be tried.
What is silostazole?
It is a phosphodiesterase 3 inhibitor, sir.
3.
Correct.
Is it 3?
3.
How many phosphor?
Phosphodiesterase inhibitor.
Sir, phosphodiesterase inhibitor, sir. It will cause, prevent the platelet aggregation and also vasodilatation, sir. So,
Indication.
some
Headache,
headache
dizziness is
patients
there.
may develop a severe headache.
Is it a contraindication?
Contraindication.
The commonest complication is a headache. 30% of the people will develop headache. Okay, if the patient is having headache, what will you do?
Sir,
You gave a silostazole and second day patient is coming back, Doctor, I see your headache. What will you do? Will you stop
We
it or?
should start with the minimal dosage, sir.
Yes.
First.
Then
Then
you're a
Increase the
practicing,
dose.
you're a practice surgeon in Kolachal next year. So what will you do? You cannot stop the medicine immediately. One is you can reduce the. What's the usual dosage?
100 milligram BD, sir.
Okay, you can make it 50, and
50.
then one more thing is, you can give some analgesics. Usually they will respond. What's the contraindication? Sorry, it's asking. Some cardiac complication?
Pulmonary. is the-
It's a cardiac failure.
Cardiac failures.
Cardiac failure is absolute contraindication. You should not use it also till, yes. What's the role of rivaroxaban in this patient?
Antithrombotic, no role, sir.
There's a new studies are coming up.
They are causing a
Lot of new studies.
increased flow, sir, decreasing the inflammation, sir.
It reduces the thrombus formation inside the smaller vessels. So you give 2.5 milligram rivaroxaban twice a day along silosol is the new regime of management. Okay.
Thank you, well done.
Thank you, sir.
It's excellent. You answered most of the questions. Congratulations.
Thank you.